Welcome, everyone. Um, just wanted to say good afternoon and welcome to our U of T Mississauga's three-part webinar series entitled Do Later Life Healthcare Transitions Have to Be This Hard? This is our first session called So Many Needs, So Little Time. And before we begin, I'd like to share a little bit about my background. My name is Rafaida Mohammed. I graduated from UTM in 2014, and I'm so happy to be here with you today, representing my fellow alumni. I'm a social worker and a mental health clinician with a background in working with a number of non-for-profit organizations in the community over the years. I've had the honor of developing and leading numerous workshops in addressing critical mental health issues, especially over the pandemic. And over the pandemic, I was able to create a web therapy program to ensure that support was accessible when it was needed the most. I'm passionate about making a positive impact and helping others navigate their mental health journeys. And so now, although this event takes place online, I'd like to take a moment to acknowledge this land on which the University of Toronto operates. And so we start by acknowledging that we are on the traditional territories of Treaty 13A, 14, and 19 of the Mississaugas of the Credit First Nation and unceded territories. We are grateful to the Mississaugas of the Credit First Nation as the caretakers of this land and recognize the benefit we receive from this land. This land continues to be home to a number of First Nations, Inuit, and Métis people. We thank them and other Indigenous people who have walked before us and share this land with us. Thank you. Over 500 alumni and friends have registered for today's webinar. That blows my mind. I'm like, wow, this must be such an important topic that we need to bring it to air. Which shows that many of us have this shared understanding of the challenges that we are facing, either with parents or loved ones as they age through their baby boomer years, I would imagine. And so just before we begin, just a little bit of housekeeping. So following the presentation, there will be a moderated question and answer period. And we encourage you to submit questions using the Q&A button at the bottom of your screen. If you experience any technical difficulties, please use the Q&A button again to send a message that you're having technical difficulties, and one of our staff will be happy to respond to you privately. And now I'm delighted to introduce our presenter, Heather Snyder. As a teenager in Oakville, Heather was introduced to the world of elderly care by way of early employment in assisted living and helping family members through their palliative years in home. Champion Family Consulting was conceptually born in 2007, while professional opportunities in hospitality, adult education, sales, leadership training were helping Heather to build an arsenal of complementary skills. With the support of her family, the mom of two added nursing to her repertoire. Well done, Heather. With a compassionate, creative, and out-of-the-box approach to classically confounding challenges, Heather has an imitable flair for clearing the fog surrounding later life transitions. Also to note, during our Q&A, Heather will be joined by her colleague, Anne Russell. So now, without further ado, welcome our guest speaker, Heather Snyder.
Thank you so much, Rufida. I am just going to share my screen with you so we can get started. Just get that rolling here. Okay. All right. Does that come through for you okay? Okay. Awesome. Well, yes, thank you so much, everybody. We were so excited about the response to this. This is a topic that has been very near and dear to my heart for a very long time, and similarly to Anne, who's going to be on the Q&A. We'll just go into show you what we're going to be talking about today. We're very, very grateful for all the questions that were sent in ahead of the session today. We're going to do our best to address as many of them as possible within the presentation so that we can explore new content during the Q&A, because I know that was something that we were very excited about as well, that a lot of questions came in, which helped to sort of direct what we did here today. Throughout our talk, you'll hear us use terms like patient and client. We're going to use them interchangeably, depending which area of healthcare you find yourself in. You'll hear both being used. So that's what we're going to do here as well. And we're keeping in mind throughout all the content here that everyone has had very different experiences within the healthcare system. And it is anything but a one-size-fits-all approach when it comes to later life transitions. We'll also be using our main case client, Mr. Khan, as well as a few other real-world examples from CFC's past and present clients, but we've switched up some names to maintain confidentiality. So we're going to talk about Mr. Khan. We'll sort of provide a brief synopsis of his situation and family structure, the levels of care in Ontario. So this is where we're going to provide clarification on what makes retirement homes different from nursing homes and lay out the various levels of care available here in Ontario for Ontarians with health cards, as well as corresponding costs and pathways to entry. Because what we have found is that that is a very confounding, very confusing area of healthcare for people. We're also going to talk about healthcare teams and key contacts. So exactly what it sounds like. We're going to talk about some of the main healthcare professionals you come in contact with later in life, as well as various sources of funding. So we don't go too deeply into this one, but we want to outline a few sources that advocates for others may not know about without asking the client or patient in question. So sort of some of those not exactly hidden, but lesser known questions to ask. And then where patients and families can push back and how to do so effectively. This one, we so often hear stories of families who have been told, it's time to go, it's time to leave, we're discharging you from the hospital. But this is happening prior to steps being taken to ensure safety, pain management, mobility, and other key needs are actually covered and set up, which unsurprisingly lands them right back in the hospital shortly thereafter. So we'll talk about some ways to mitigate this situation and set you up for success. And then finally, how to plan and advocate proactively. This is kind of the big overarching topic today that sort of seeps into all the different things that we talk about. And it really is, how can you hope for the best, but plan for the worst and be as knowledgeable and prepared as possible for later life healthcare transitions. So that's kind of an agenda at a glance for you for today. So Rufat already gave you a nice little summary of my background and qualifications. I'll also just tell you really briefly how Champion Family Consulting, CFC for short, came to be. I had entered into an RN program back in 2005, but I'd left halfway through it and switched to a business undergrad because at the time, I felt I could perhaps impact a greater number of people from a possible managerial or sort of business standpoint. And B, I was disheartened by what was happening in the healthcare space, both for staff and for patients. Fast forward through the various careers that Rufida mentioned, and I finally came back to nursing, and I'm at 3 hospices in the KW region. And the business became a reality at a time when this type of information, support, and advocacy is needed more than ever. And my business partner and our care and client coordinator, she has sat in all the seats, community, hospital, home care. She's been a caregiver for her own family members. She did discharge planning for 30 years or so, and in recent years has been nursing supervisor at Huntsville Hospital and helped head up the team that opened the Huntsville Hospice as well. So her knowledge and instincts when it comes to family strategy and care planning are second to none. And so we're very lucky to have her here for the Q&A session at the end. So our friend here, Mr. Khan, he is a 78-year-old male. He has a 77-year-old wife. Both of them have English as a second language, but they do have two adult children who luckily live pretty nearby. So they're both within about a 30-minute drive. He's recently had a stroke that has landed him in hospital. So he is still currently in hospital now, and has left him with some right-sided weakness. He also, prior to the stroke, had been diagnosed in the early stages of dementia. So we're going to use this as sort of our baseline client, and we'll keep kind of referring back to him. If we were in Mr. Khan's case, so if we were in his family unit, his partnership with his wife, and anyone who's been in this situation before can probably agree that these are the types of questions that start to go through your mind. What now? What do I do now? Who do I call? I know I need help, but oh my goodness, where do I go? Well, depending on your background with this, you may recognize these names here: home care program, CCAC, LINS, HCCSS, Ontario Health at Home, and the at home is not a typo, that's actually how it's branded. But the main thing here is these are all the same thing. This is an Ontario-based support program that is government funded, and it's kind of it's sort of your first go-to if you're an Ontarian needing help in healthcare. So Ontario Health at Home, which was just renamed in July of this year, is the current branding. So if you're Googling it, you would Google Ontario Health at Home. But from what we've heard and what we understand from our clients, this can be very confusing because the names are still being used interchangeably, even within the system. So depending on the teams that you're working with and healthcare professionals that you're encountering, they may drop oh, I was talking to the LINS the other day, or though the CCAC did this, or HCCSS. The main thing to take away here is it's all the same body. It's all the same thing, arose by any other name in this case. So really what its goal is, no matter the name, the goal is the same. It hopes to be a sort of a one-stop shop for Ontarians looking for help. Supply and demand, however, I know we're certainly aware of the supply and demand issues within healthcare in general, but there's a supply and demand issue at the Ontario Health at Home level as well. We've got so many people needing help, so many people needing support, and there are only so many case managers and caseworkers who can come out and see you. So this is, again, where the advocacy component can become very, very important. So having somebody that doesn't need to be related to you, but just somebody in your corner who can help to make some calls and help kind of stay on top of it, because with OHH or Ontario Health at Home, following up and following up and following up does tend to kind of get you a little bit further ahead a little bit faster. The other thing here for Mr. Khan particularly is, you'll see here I've listed interfamilial resources. Mr. Khan's one son is actually a hospital RN. So I wanted to make sure we talked about the fact that when you're running into crisis, or you're at the beginning stages of what could become a crisis, it's really important to lean on those around you who have the knowledge and expertise that you don't have. So in sales, this would be your low-hanging fruit. So you'd gain information and insight from the easiest and closest sources. When we look at levels of care, in your PowerPoints that went out to you ahead of time, you'll see we've used this staircase of the levels of care a few different times. We broke it out into a few different areas to kind of highlight all the different components that exist within this staircase, starting with what is appropriate. So what level is appropriate for the patient or the client in question? So many times there's confusion around, well, a retirement home is the same as an assisted living home, or if I say long-term care, I could be talking about a retirement home but not knowing it. So let's clarify what each of these pieces actually mean. The personal home down here on the left That's pretty self-explanatory. The client returns to their own home after potentially a hospital stay. However, questions of mobility, safety, accessibility, and cognition must be addressed if the client is returning home after a hospital stay or health event. Mr. Khan's primary wish is to return home with his wife. Following his stroke, however, he was left with that right-sided weakness that we talked about, and that has made it difficult for him to ambulate and has made stairs very unsafe. So is there the ability for him to live exclusively on his main floor? Is there a bathroom on that floor? Is there a living room or dining room that could be converted into a bedroom? Various questions like these can and should be addressed now. This is exactly what happened actually in Anne's family. She took in her uncle into her home, and after he had developed Parkinson's and dementia, and converted a main floor living room into a separate bed sitting room. And I mean, this is almost everybody's primary goal, is to stay at home as long as possible. So that's fine and dandy if it is safe and if it's safe for all those involved, including the family members and the patient, of course. The next step here on the retirement living, retirement homes are still quite independent living, but they have supports available like meal preparation and service, 24/7 on-call personnel. They also have in-house supports like meds and personal care as needed. Those can be added as needed. And this type of setting also helps to offset loneliness and isolation. They've got social programs, shared meal times, activities that can be opted into or out of anytime. So sort of a bit more of a social opportunity than what you might have in your own personal home, depending where you live. The main differentiator for retirement level care is that most residents who live in these facilities are able to perform activities of daily living independently. So activities of daily living, ADLs, which you'll probably hear a lot. If you hear this term thrown around, it refers to things like bathing, dressing, toileting, transferring, eating, and continence. So basic skills that are required to live independently in a household. When you hear ADLs, and you will, this is what they're referring to. And this is used across a lot of different teams and a lot of different settings. When you move one step up from retirement to assisted living facilities, this is very much like a retirement home. It's like retirement living, but with extras. So generally it's either on a separate floor or section of a facility, if it is combined, or a completely different facility on its own that offers more baseline care options to residents than a retirement home would, as a starting point. And it's at a higher starting cost because of that higher level of care. The first facility I ever worked at back in 2003 or 4 was as a care manager at Sunrise Assisted Living in Oakville. So that was a completely dedicated assisted living facility. Very beautiful, very cozy, very well kept, sort of upscale living sort of option for those whose ADLs were compromised and needed a bit more help than what was available at home or at the retirement facility level. So not a lot of people know about assisted living at this point. Nursing homes or long-term care, that is truly a interchangeable term. So if I say nursing home, I'm talking about a long-term care facility and vice versa. These are where the level of care is much higher than the previous two. Most ADLs are compromised at this point. 24/7 care for things like toileting, eating, bathing, and mobility is generally utilized by the patient and client population within long-term care. And it's mostly because they cannot receive this level of care in their own home. Chronic care, this is usually provided in hospital on special floors. The care needs are more complex than can be managed in the nursing homes. These would be things like higher oxygen levels that are needed, ongoing treatments requiring specialty equipment and personnel, fluctuating symptoms that require more skilled expertise that, an on-call specialist, that kind of thing. So that would be hospital-based. And then finally, hospice and palliative care. Hospice facility is its own residence. that provides palliative care. Palliative care, of course, is end-of-life care when a life-limiting diagnosis has been given. Usually what that means is about 3 months or less for a prognosis to be admitted into a hospice residence. And this is actually done through a palliative care physician directly. So this is palliative care itself can be provided basically at any level along this staircase that you see here. It's just that a hospice residence is sort of better equipped than most to deal with the needs at that level. So again, if we're talking about what is appropriate, after each of these staircase slides, I've given you a few sort of food for thought kind of questions to kind of just tuck in the back of your mind for later. So is the person medically stable? Medically stable meaning that the patient's condition is sufficiently controlled or managed so that it's not life-threatening at this time, and they're not requiring immediate intensive medical intervention. What were their capabilities prior to the downturn in health, and are they expected to get back to that? So if you think about Mr. Khan, we want to know, what were his capabilities prior to the stroke? Are we expecting him through rehab and maybe physio to get back to that level, or do we need to start making changes in the home to make it more safe and livable for him? Is the person competent and capable of making decisions? Again, this calls into question things like decision-making and cognition. So indicators suggesting competence can include things like a clear and accurate understanding of their own condition, the ability to articulate the reasoning behind their decisions, consistent decision-making that aligns with their values and preferences, and of course, being free of undue pressure and coercion in that decision-making. That's very, very important because we want to make sure that the patient is of sound mind to make these decisions for themselves. Also, being able to weigh the risks and benefits, of course, is very, very important. What resources exist in the family and household? So again, if you have someone in the household who is able and willing and physically safe to provide care on an ongoing basis, that could be a very different situation than someone who lives alone. Have any physical or mental competency assessments been done? This is really important as well because these assessments are done through Ontario Health at Home to begin with, but on a more sort of a mini mental 3-question assessment to start with, and usually, drawing a clock to make sure that your cognition is there. But then more in-depth assessments can and should be done by specialists who are trained to do these things, such as occupational therapists, neurologists, psychologists, and the like. So these are just, again, food for thought questions. If you run into some of these situations, you can kind of refer back to this and say, okay, like, have I got some of my ducks in a row? So then we'll go back to our staircase here, but instead of looking at appropriateness, we're going to look at availability and how that works. So entry to care. So the personal home, again, is dependent on the layout and the care needs. We want to make sure that we have things in place that make it safe, that if that means it's a stair climb, stair lift, bars beside the toilet, a different kind of shower, we need to figure that out before that person gets back into that living space. Retirement homes, when it comes to availability, generally speaking, there isn't much of a wait list. They're pretty much available to anyone whose care level is appropriate. So again, pretty independent living. ADLs are pretty much independently being done. And for the most part, you can go in and you can tour retirement homes and say, okay, this is the one for me. Here I go. Assisted living is a little bit similar, but the facility equipment and staff should be assessed because that assisted living level is a bit higher in the care needs. It's important to make sure that that particular facility is equipped to meet those care needs before moving in. The nursing home long-term care level here, that's where we get into the wait lists with Ontario Health at Home. So Really, really important to include Ontario Health at Home really at every stage, just to make sure that you are getting the most out of what is available to you and you're accessing all of the different resources that you possibly can. But this waitlist through OHH, that's the one that you probably hear a lot about, and you probably heard about Bill 7 a couple of years ago was revamped, and there's been some changes that have taken place with regard to how the waitlist works and where you can put some options and top 3 or top 5 of your options of where to go. We always recommend to our clients that you can list up to your top 5 requests for long-term care facilities. And that doesn't all have to be in your geographic area. You can also select where your family members are and get kind of creative with it. But again, you really want to have that relationship with the Ontario Health at Home case manager, because they can also help you with that a lot. Let me see here. Chronic care level, as far as availability, it fluctuates quite a bit because it's dependent on symptoms and care needs. So we said in the last couple of slides that chronic care really is for patients who require some of that more specialized equipment and specialty care. This is usually a patient who's transferred from another facility or hospital floor when a bed becomes available. And this is based on assessments of that patient's condition. So severe congestive heart failure would be a good example here, that with respiratory crises, that would be someone that you might find in a chronic care situation. And then for the hospice, as I mentioned prior, if that life-limiting diagnosis has been given, the palliative care physician at that point would put through a referral to the hospice directly. And generally speaking, the wait times they're not as long as the long-term care wait is. Things like pain management, comfort care, those are really what hospice and palliative care is focusing on. So, the hospice is equipped specifically with all the right comfort measures and medications. So that palliative care team is really usually going to want their patient to be in the right spot. And that's usually it. But really, as I say at the bottom there, try to involve OHH as much as possible whenever possible. So food for thought questions on availability. Are you or is the patient in crisis? Geographically, how many options are there? Where are all personal familial resources located? Do you have to go through OHH management to making a change or move, which again, not so much with retirement, but yes, for long-term care. But really just kind of start to get you thinking about some of those next steps. And then finally on the staircase one more time, we look at affordability. The personal home, again, with it being the top choice for people to stay, you have to consider the fact that your living costs likely are not going to get lower. Your living costs as they were will remain the same, and then your care costs will go higher. So if you're going to hire people in, hire in extra help, extra equipment, that's something that needs to be planned for. With retirement and assisted living facilities, there's no government subsidy. There's no help from the Ministry of Health as far as that is concerned. So when we talk about affordability, retirement and assisted living tend to be the highest out-of-pocket expense. Nursing home and long-term care, however, the Ministry of Health does cover the care portion, but they do not cover the room and meals portion. So this can be kind of scary for people who previously thought, oh, well, if I'm on a wait list and I get into a long-term care bed, then I'm great and I'm good and that's my bed and I don't have to pay for it. That's not exactly accurate. There are still costs. It just might not be as high a monthly cost as the retirement and assisted living levels. Ontario Health at Home's mandate, however, is that every person in Ontario should be able to afford a basic long-term care bed when they need one. So there are top-ups available and there are sort of workarounds that you can utilize to make that possible. Chronic care differs from the hospital stays as it it really becomes your home. So it's not just a hospital stay. This is really your home for any given amount of time, but it requires a copay from the patient, usually monthly. And that's just simply due to, it's beyond the usual level of the hospital care. So the patient kind of helps to offset some of that extra cost. Hospice facilities are truly the only place where there is zero cost to the resident and the family. That is because it's under a completely different model. And the Ministry of Health does cover wages and salaries for staff and essential medical supplies like needles and syringes and that kind of thing. But then all other costs, including upkeep, residence overhead, utilities, furnishings, food, beverages, blankets, lights, all of it. Those are all funded by fundraising efforts within the residents, and then donations. They rely really heavily on donations from families and community members and that kind of thing. So when we're looking at affordability, then how much does each level cost? I'm giving you kind of a really broad level idea here, because of course, within each of those different steps along the staircase, there's huge variation. But now we sort of know which levels are subsidized and which are not. Can spouses move too, and at what rate? I mean, in retirement, generally speaking, the second spouse, so if one spouse moves into a retirement home first, the second spouse can usually come in at a reduced rate. It doesn't matter if they move in at the same time as each other, or if one moves in later. They kind of like a buy one get one half off deal. However, at long-term care, that is not the case. So there's no second person discount rate in long-term care or nursing homes. And again, that's just simply due to the level of care required. So, government subsidies for top-ups for the spouse who still lives at home, those are something that we can look into as well, because if you have a spouse that's still living at home and now a partner who has moved into long-term care, your overall costs monthly have gone up from what they previously were. So there are top-ups to kind of help that spouse that's at home remain at home as long as possible as well. And then insurances and sources of funding that are earmarked for this purpose. Well, I kind of briefly mentioned this earlier, that there are some things that people have in place kind of in their back pocket, in their portfolio, that generally speaking, they don't talk about at a dinner party or, at around the dinner table. So if you're advocating for someone or you're helping someone navigate through this, these are some of the things that you can ask about. It might be a no across the board for all of them, but things like Veterans Affairs, RIFs and TFSAs, programs like Green Shield that Ford offered, union and pension insurances, spousal supplements, caregiver benefits, which essentially is a type of EI, reverse mortgages, and long-term care insurances. Not all of these are available to start into them now, but if people had bought into them or were part of them earlier, they may still be entitled to money from them now. So it's just important to ask about it. And that's what brings us to Anne's 4 A's. So many years ago, when she was working as a discharge planner, Anne developed the 4 A's of proactive, advocacy, and planning. So we talked about appropriate, available, affordable through all of our little staircases there. But if at the end of all of that, the next step or that next idea is not acceptable to the client or the patient, you got to go back to the drawing board, because really, at the end of the day, it has to be acceptable to the person who is moving. I'm assuming in this case, we're looking at either a move into a facility or a move back home with some changes. Some of the healthcare teams and key contacts you'll run into, which I'm sure a lot of you have already. Hopefully you have primary care, like a general practitioner or family health team, the Ontario supports that are available to you. So the Ontario Health at Home that we've talked so much about, specialties like oncology, occupational therapy, physiotherapy, the geriatric teams, palliative teams, rehab. And then in those residences and facilities that we talked about, they also have a really robust amount of resources and supports that are in place for those who move in, and also for families as well. There's nothing wrong the one thing I will say is that when you are talking with all of these different teams and encountering them, you're going to hear a lot of lingo, you're going to hear a lot of acronyms, you're going to hear a lot of sometimes conflicting, what sounds like conflicting information. There's nothing wrong with asking for clarification. In a lot of cases, just logistically, these teams aren't necessarily talking to each other. They're talking separately to you. So if something's not adding up, please just ask for clarification, and there's nothing wrong with that at all as the family, the patient, or the advocate. That being said, you are going to be dealing with a lot of different people. And we also know that supply and demand is a real issue. We are short-staffed, we're overburdened. There's way more demand than there is supply. So as the advocate and the patient, this becomes more like a relationship building project. If anyone's worked in food and beverage before, it's kind of like walking into an overly crowded restaurant for dinner. And the kitchen's backed up, the servers are scrambling. Every time a server passes through the dining room, 10 tables put their hands up and are asking for God knows what. Using this analogy, you can find a way to be the table that the servers want to go to and want to help out more. So the question really is, how do you get the best care from your teams? I'm sure a lot of you have heard the saying, if you want to gather honey, don't kick over the beehive. We have to know how staff and capital shortages affect us. So you need to become a big part of that team. You want to be the squeaky wheel without being too squeaky. If anyone's read Dale Carnegie's book from the 30s, I'm basically referring to some pretty simple things that are back in his teachings. Smile at these people. They are stressed, they're overworked too. Smile at them, learn their names. Ask questions from a place of confusion as opposed to defense. And if you can, provide as much relevant information as possible. So if you have personal history, experiences, cultural needs or concerns, past traumas, important traditional practices, share them with your team and empower them to help you better, because that's really at the end of the day, that's what they want to do. And this is really just you steering the critical path and the core objectives. So how do we get to that place that we need to get to? The healthcare team, like I said, they're not mind readers. Around the regulations and red tape with hospital discharge, we did have a client last year who had open heart surgery, came out of surgery, and the surgeon came and said, okay, it's time to go. You're being discharged. Because from the surgeon's perspective, he was medically stable. Well, the problem with that was that he lived in a very, very remote area, kind of up in the Ottawa, Quebec region, very few resources around. And this was leading right into the Labor Day weekend of 2023. So no one from home care had come to see him yet. There were a lot of things still left undone and left unplanned, and there was nowhere for him to go safely because he couldn't go home and be safe on his own with no caregiving. So Anne actually was his care coordinator at the time, and she got on the phone trying to get options of different convalescent places where he could stay. But the problem being that on Friday of the long weekend, no one would actually be in administratively to admit him until Tuesday. So the main point here is, as an advocate, if what comes next and what they're proposing is coming next, you're not ready for safely, then you can push back and you can say, no, this is the situation that we're in, but here are the things that I have in place, and here are the things that I've planned, and here are the upcoming steps, and here's the date that we can go. So the magic here is having factual objectivity as the advocate. So cool as a cucumber, facts, try to steal those nerves and steal that stress and that emotion that comes out in a lot of these situations. And try to use language like, help me understand. And if this were you, your mother, your spouse, whoever, what would you want? What would you do? And that can kind of turn the conversation around in a really magical way. So I think we are bumping pretty close to our time here. So Um, for our session today, I know we kind of just burned through a lot of pretty big stuff pretty quickly. The key takeaways, I think, are keep in mind, hope for the best, plan for the worst. If we plan for the worst and it doesn't happen, awesome. But approach everything proactively, not reactively, whenever possible. So that's just the same thing. Try to see it coming, try to see whatever you think could possibly happen, plan for it. And pretend you're not the customer. This whole customer's always right mentality, we can't use it in healthcare anymore. Be the client that they want to help. Be part of that team and be your own advocate, because no news is not necessarily good news anymore. You might have slipped through the cracks, and by no fault of anyone, and it's not personal, it's just logistically, this is what's happening. So follow up, follow up, follow up some more. And then I'll just give you a quick little synopsis here. This is looking ahead to session 2. So if you're coming out of this one and wondering about what about powers of attorney and substitute decision makers, having all those difficult conversations, we are going to talk about that in session 2 on December 3rd. And then I've also put on here, and I think you guys can maybe send this out as well. As questions arise, you can email us at the admin email to try to incorporate some more information into the upcoming sessions. And then I've also added some additional resources here, just for some quick, I know there were some questions that came in prior to today on, public reporting on standards of LTC homes and health and community services in your area. And then, of course, the first line here is Ontario Health at Home's direct line phone number. And I think that was all I had for you right now.
Great. Thank you so much, Heather. We're going to just lead into our Q&A. I know there must be so many questions that people have. I know I do. So if you have any questions, just as a gentle reminder, please use the Q&A button at the bottom of the screen, and we'll aim to capture as many questions as we can. I'd like to now welcome Anne Russell, who's joined us specifically for the Q&A section. Just a quick intro about Anne, a registered nurse in her early 20s, a graduate of the Public Health Nursing Certificate at the University of Toronto, and started out at a Red Cross outpost hospital in Minden, Ontario, before finding her favorite role as a discharge planner at Oakville Trafalgar Memorial Hospital for about 30 plus years. It's stellar. She has gone on to roles as nursing supervisor, hospice RN, before becoming Champions Family Consulting's client and care coordinator. So I'd just like to welcome Anne. Welcome, Anne. Thank you. So I'm going to jump right into our first question here. So it's, how do you convince elderly family members to make changes to living arrangements before they're ready? Very tricky, difficult to navigate. What are your thoughts?
A very good question. The short answer is it's unlikely that you can until they're ready. And as Heather has mentioned a few times, just about everyone wants to stay in his own home. And that's how I feel. That's probably how you feel too. But it's a really important conversation to start. And you need to listen and be patient and kind and be respectful of their wishes, because there may be a lot of things that you don't know that's going on. And by listening, it might be revealing of why they really don't want to move on. There's so many factors involved. And change is very, very difficult. People have the right to make bad decisions, which I've had to support in many, many cases. And just referring quickly back to the case that Heather talked about, with the fellow going to the Heart Institute, and he really wanted to go home, but he wasn't able, so he did go to a retirement home for convalescence, ended up staying there for 8 months, but wasn't very happy. But it's where your condition drives the plan, where he just wasn't well enough and needed that support. But after 8 months, he insisted on going home. You know, he wasn't really well enough, but he was cognitively able to make up his own mind about that. And so I helped in that move back home and set things up for him. He is at risk, but he's managing not too badly. But there's a backup plan. And the backup plan he agreed to, and we have his name on a list for affordable housing. Those lists are very lengthy, but it's a place where he's a veteran and there are other veterans, and he would have his own space. He could have his pet. And having a pet at home is another huge factor in people wanting to stay at home. So there's a lot of things like that that we wouldn't necessarily think about, but it's significant in where the next step is. And I thought, you know, initiating that conversation with your family or a good friend, it's often easier to start with a story, and it depersonalizes things. Then it's not, it's less threatening to say, I have heard of this, or I have a friend. And from my own personal family, I have a sister who has a spouse who became ill, had to have surgery. It went all right, but he never regained his strength or his health after that. They were living in a 2-story family home. And after a year or so of struggling and the worry about maintenance and all of that, they decided that neither of them wanted to be left in this home, this big home, by themselves with that huge job of having to downsize alone.
Wow.
And they didn't want their children to do it either. So they got together and they put their heads together and they sorted out a lot of issues, where things were going, what they would take with them. In the meantime, found out sort of all the options that were available in the community, where they wanted to go, found a condo that they really, really liked. And when something came up, they made that move with the help of family at the time. And it's just been a blessing. And they've been so very grateful and happy that they did that move, as each of their health has deteriorated over time, but they're managing and they're just very, very happy with that decision. So using that as an example, it's, you know, with respect, listen, have the conversation, try to demystify what's out and all the options that are out there, and support them in their decision.
Yeah, that's a brilliant, like traversing care and advocacy for those that you care about, family members, and let alone the individual who sometimes voices gets lost, right, in conversation, right? Loved what Heather said earlier about like teams talking separately to you and not talking to each other. Right? Like, so you're saying the same bits and pieces of information to like different bodies of people, and you're just repetitive. You may even question like, what's not getting through here, right?
Yeah.
Like, what are people not hearing about my wishes? And that story just speaks about the advocacy and having this couple kind of move at their own time, at their own pace when they were ready, with still having the support. So yeah, that's quite impactful.
We
There's
found
another,
too,
yeah,
Rufina, we found too that the importance of keeping really almost like a journal type notes
right,
with those family members, because even just having the conversations and making a little note here and there as the conversations happen, it's nice to have something to refer back to, like, oh, remember we were talking about it and you said you'd be open to maybe this idea and we talked about this, so that it's
yeah,
not just, it becomes very confusing and very messy mentally. So having really good lists and notes is helpful, not only in those family conversations, but also in going to all of these different teams, so that you're not having to regurgitate and worry about making sure that everyone has the right information, because you just have it on you have it in your little notepad. So that's really
right,
a good method as well.
of preparing. There's a question here that's come through in the Q&A box. I just wanted, because I think it ties in quite nicely. As someone who doesn't have supports at home, with no family present to assist in planning my later years, how do I, how do you recommend, I prepare when I'm not as healthy? How can folks who are almost alone make this transition easier?
Probably the Ontario Health at Home, their mandate is to try to keep people home, support them, and connect them with the appropriate resources. So I think that would be the first call that, hopefully a doctor's office or someone visiting or a friend, could have them move into that realm. And that's where probably the most information, support, and assessments would come from then in that case.
Yeah. Okay. Heather?
I would say also too, if there are, I mean, we have lots of people who don't have family members to help them in this advocacy capacity. I always recommend if you have anyone in your life, whether it's a friend or a coworker or an old colleague, anyone that you know of who has had an experience that either you thought was really positive, or on the flip side, you thought was actually really negative and you'd never want to see that happen. Try to tap into those people to say, okay, what did you do? What was your experience and what steps did you take to get to this level that I thought was really great? And then on the flip side, how the heck did you end up where you ended up that I never want to be? Like, it's a
Right.
very, try to just ask questions of those around you. And for the most part, as long as it's not too personal, people love to share their experiences. And so it's usually very well received.
Yeah, it sounds like you're tapping into one of our questions about advocacy. So how can I be a good advocate for a loved one? And I want to also preface that by saying, like, how can I be a good advocate for myself?
Yeah.
Mhm,
Right?
mhm. The first thing that comes to mind for me is if you care, you have to be there.
Mhm.
Because in order to be a good advocate, you need to have the facts. You need to know the trajectory of sort of an illness by asking questions. And if you're informed, it empowers not only yourself, but your loved ones to make proper choices. Um, a really good way to do that and to find things out is to go on appointments, offer to go on appointments with your loved one. Or if it's yourself, ask someone to go with you, because you can't imagine when you're unwell or under a lot of stress that you don't hear and remember what's being said. So another pair of ears is just so invaluable. Aside from the support, it's just the facts and the information and the follow through of what you're going to do. So that to me, and I, even with friends, I go on appointments. I'm invited to go, or you offer to go, because the other thing is, as people get older, well, any age really, is the hearing. If the hearing isn't as good, and people often don't realize that it's not as good as in your younger days, but with the loss of hearing comes loss of the ability to process information, which many people don't realize. And a lot of older people don't want to go into hearing aids or anything, and maybe they're not able to either afford or just manage it. So having another set of ears, someone with you, again, for that reason, and because your senses aren't quite as acute, perhaps your sight isn't as well, such a good thing, to have and to go along with. Advocacy, and a quick story from my experience in the past, was being an advocate for somebody in the hospital. So it was a situation where an elderly woman came into hospital because she'd been living independently at home. She'd had a fall, came to hospital. They sent her right into x-ray. They x-rayed her hip to see if there were any fractures because she was in a lot of pain, and nothing showed up. So it's like, now what do we do? She's in a lot of pain. She can't weight bear, but nothing showed up. So, people sometimes get labeled, that, oh, what are we going to do? Well, you need to go home because there's nothing we can do to fix this. So that's where the advocacy comes in as well. As the discharge planner in those days, I spoke to the family. They were very concerned. Like, what are we going to do with mom? And I spoke to the patient, and she'd never been a complainer. She was independent. Her desire was to get back home. So I asked the team, I asked for further investigation, which you have every right to do, to say something doesn't make sense, this isn't right. They ended up doing a bone scan, which shows things up much more clearly, and it revealed a fine crack right down her pelvis. And
Right.
so no wonder she was in a lot of pain, and no wonder she couldn't weight bear. And
Right.
then, the plan was that she had to be on bed rest for 6 weeks. Pain
Unbelievable.
control all of a sudden was being addressed. her needs, support was there. She ended up recovering, going for a bit of rehab, and returning home. So the point is, if things don't feel right or look right, maybe you're missing something, and that's where that advocate comes in. Because as Heather mentioned, the people are so busy, the team is so busy, and they don't know you as well as you know yourself or your family know you. So that's really, the takeaway is to be informed and have the right information, um, and have a valid plan. So, the valid plan for the fellow at the Heart Institute was, we have a plan. It's just going to take 3 days to put it into effect, but it will be successful if we do this. And for her, it was, let's get the right information, let her heal. And the plan is absolutely, let's go home.
And I
I
do
think,
want to mention really, really quickly too, to tack on that if you require, I mean, Ann and I were talking about this before we started today, there are tons and tons of different interpreter and translation services that are available now through healthcare specific interpreters and translation service companies, so that that information can be conveyed to the patient in an actually sensitive and accurate way. So if folks are running into anything along those lines too, there are lots of resources available to make sure that the information is getting conveyed both ways, properly and accurately.
yeah, I appreciate. There is this stream of questions coming in. I want to get to that. It sounds like these appointments can be a multitude at a time, or in a period of a framework of like a couple of months, and then also they're quite packed with a lot of information. So even taking stuff, information away, documenting it, and processing, and thinking about how it resonates with you, and what your next steps can be is duly accounted for when dealing with very, very delicate matters, and trying to navigate the best way you can while keeping the patient or the client at the center of it all. So now appreciate that. So there's a question here. Maybe I can try to tie two into one as we're just at our mark now, for closing off. So my father has a progressive disease. My parents live in an apartment, and he's fine for now, with his wife's support. When would it make sense to reach out to the OHH? And then just, I'm going to throw this one in just really quickly, is that a similar scenario with another individual. This client or this patient has not seen their family doctor in a few years, and are there resources, again, that this person's father, that the family doctor can connect them with, or even, with the oncologist maybe be able to connect them with. So I think these both are kind of banking on resources more specifically. Might have just a minute or two for that, and then we'll have to close off.
It's really up, I guess it comes down to the client or the patient too, is having that conversation is, are you ready? Are you ready to go to the next step? Could we connect with your doctor? The doctor, oncologist, they all absolutely can put referrals in. If you haven't seen your doctor for a number of years and you're elderly, it would be very good to make an appointment and accompany that person to that appointment. So it's that next step is try to be proactive instead of waiting until there's a crisis. And it has to be, though, with the permission of whoever you're looking after.
And
Okay.
be organized and start that case file as though you're the case manager now, and from day one start gathering the information in all one spot, so that will make your journey that much easier and smoother.
So just clarifying that, a referral to a hospice care, can that oncologist maybe make that referral? Yes.
Mhm.
Yeah. Okay.
Yeah.
And then just the question before that was, when would it make sense for the individuals that were, living at home in an apartment together? Things are fine for now because they have the support of each other, husband and wife. When would it be a good time to maybe make that referral to OHH, just quickly, as we are now at time?
Any time would be a good time, because then you get a phone call and chat about your situation. They might be able to offer some resources that you haven't thought about just yet before you get into a crisis.
Yeah. Do
Okay.
it now.
Thank you. Thank you both. And for everyone attending here today, it appears that we're at time. And so to our audience, we received a lot of questions. I apologize, we're not able to maybe get to yours. We're looking forward to our second part of the series on December 3rd. Building on the foundations of session 1, it'll explore the importance and influence of powers of attorney and substitute decision makers. It will offer tips and techniques for initiating and navigating difficult family discussions. It will aim to give clarification of the do not resuscitate order, and it will also deliver key pieces of information that every family needs to know before facing a crisis later in life. So on behalf of the University of Toronto, Mississauga, I'd like to thank Heather and Anne for their time and their insight and their wisdom and just sharing their knowledge and experiences and answering questions from our alumni audience. Everyone who registered today for this event will receive the link to record to this recording in their inboxes, and along with this recording you have an option of doing a post-event survey. Please do that. Please do the survey. It allows us to kind of like develop events and programs for the future based on your feedback that you provide. If you enjoyed today's webinar, be sure to check out our upcoming listings on the UTM alumni page. Thank you, Anne. Thank you, Heather, much appreciated. Have a great afternoon, everyone, and looking forward to hosting another webinar again with all of you, University of Toronto, Mississauga. Thank you.
Thanks, everybody. We'll see you on the 3rd.